Oncology. My contact information, I believe you can see on the screen there. Feel free to, interrupt with any questions, email me, call our offices. Happy to chat with any of you. I think I get the impression some of you are going to know a lot about what I'm going to talk about, so feel free to interrupt at any time. We're going to discuss a brief overview of radiation therapy and possible side effects and management options of those today. So I can't really get started without discussing February being National Cancer Prevention Month. Sometimes when we think about cancer prevention, we think about colonoscopies or mammograms, and I'm trying to get really at the heart of prevention, things like stopping smoking, maybe limiting alcohol, weight control, and in this case, there's been a lot during COVID, a lot of interest in vaccines and cancer vaccines as possibly being the way forward. I'll just kind of say that there are some cancers that are already preventable. There's a virus called human papillomavirus, HPV, for which we do have a vaccine, Gardasil being one of those in the little picture there on the left. And we know that there are, many cancers that are caused by the HPV virus. This little cartoon on the bottom right being from, I believe, the National Cancer Institute, where HPV is associated and causes cervix cancers, tonsil cancers, anal and genital cancers. And we know, based on many studies, that the HPV vaccines in the bottom left side can greatly reduce the incidence and your risk of getting an HPV associated cancer. So during February National Cancer Prevention Month, I have to discuss that. As many of you may know, there are the common things being common: breast cancer, prostate cancer in men, lung cancer, and colorectal cancer are the top four most common cancers in the United States. And as I alluded to just a minute ago, there are screening tests for all of those. So it may also be a good time to think about updating your screening profile, as well as skin cancer and melanomas there being number 6 on that list. So as we think about all of these cancers, I just wanted to point out also, in the top 10 cancers in the United States, radiation can actually be used for all of these. And so we'll talk a little bit about what radiation therapy is and how that works now. So I did want to point out that radiation is around all of us all the time, and therapeutic radiation, specifically on the right-hand side, being X-rays and gamma rays, are part of a spectrum of radiation. And radio waves, TV, your cell phones, the light that we can see, this all of part of a spectrum. And over time, humans have learned how to harness those higher energy waves of electromagnetic radiation, the X-rays and the gamma rays, to use that to diagnose, in the sense of a chest X-ray or a CT scan, or treat cancers. And that is why, according to the American Association of Cancer Research, which is one of the preeminent institutions of cancer research in the United States, that radiation on the bottom left side is one of the pillars of cancer treatment. The others being surgery, and in my small-minded way, drugs or medical oncology. The right three pillars there being chemotherapy, targeted therapies that target certain enzymes in cancer cells, and immunotherapy that activates the immune system against cancer. The medical oncologists, or the drug doctors, kind of handle the drugs. Radiation doctors handle the radiotherapy, and then of course surgeons handle surgery. So as you can kind of see on the bottom left timeline, that radiation actually predates chemotherapy as one of the pillars of cancer care. And on the right side, I always like to include some trivia and talks. One of the pioneers of radiation and radiation therapy is Marie Curie. She actually was awarded 2 Nobel Prizes for her work in radiation and radiation treatment, and is credited with coining the term radioactivity. And she's actually the first woman to earn a Nobel Prize and the first person, period, to win 2 Nobel Prizes, and one of a small group of people who have earned 2 Nobel Prizes in different fields. So, it's good to know that as a trivia fact. So, what is radiation therapy? And for the purposes of this talk, I'm going to focus mostly on what we call external or external beam radiation therapy, which is the most common form of radiation therapy. In this picture, by the way, these pictures are all from Google, so they're all publicly available, and no one's personal information is being violated. In this picture, the patient, if you will, is lying down on the radiation couch. Let me see if I can get a highlighter. Yes, the patient here is lying down on the radiation table. We call it a couch. And this big machine is delivering the radiation through this square portal here. It's a beam, not unlike a laser, kind of like a flashlight, that's not actually visible to the human eye. And this external radiation is most commonly delivered daily over the course of several weeks. And that depends on the reason why we're doing radiation and the type of cancer that we're treating. Different tumors basically have different sensitivities to radiation. And so there are different common treatment approaches to different cancers, ranging anywhere from, 3 or 4 weeks to 9 weeks for certain cancers. External radiation may occur before, after, or instead of surgery in some cases. And radiation can occur at the same time or sequentially with some of those drugs like chemotherapy or other anti-cancer agents. So, how does radiation work? Specifically, radiation has a couple of different ways of working, and this harkens back to my interest in the research of cancer biology. There is a direct damage to cancer cells, which causes DNA damage, and an indirect way that radiation can cause DNA damage. Most of the damage is through indirect damage. And that damage occurs primarily through oxidation, which also creates inflammation. So those cancer cells can't repair that DNA damage, and in fact, that's how they became cancer cells. They had some baseline level of DNA damage that they couldn't repair. And those cancer cells, because they can't repair the DNA damage that the radiation generates, or in some cases chemotherapy generates, those cancer cells die. So how does that work in a very fundamental level? In this cartoon, this is a cancer cell in this case, and these little squiggles are DNA. When a cell is trying to replicate itself, it has to create copies of that DNA. And then in a very orderly fashion, that DNA has to separate into 2 separate cells. And those cells repeat that process in an exponential way. And so that's how the normal cells replicate and also cancer cells replicate. So the interesting and important part is that those normal healthy cells that are in some cases right next to cancer cells generally repair that DNA damage. They're very good at doing that. And they survive either with a complete repair or a partial repair that still allows them to survive without any consequences in that way. So in some ways, cancer treatment and radiation therapy specifically is a balancing act. You can kind of tell already that we want to kill the cancer cells, but we also want to limit the side effects to nearby healthy cells or nearby structures. And we don't necessarily want to tip the scale in any one way, as that may limit our ability to accomplish the other goal. So the next natural question then is, how is the rest of my or a patient's body protected? If you remember that little square shape of the head of the machine where the radiation beam is emitted from, that head actually has some internal fingers that shape the beam. We call them leaves too. And I have a video that may allow us to see that. Let's see if this will play. Yeah, so YouTube, the great master of information. In that head, there's these leaves. As the machine is moving around, those fingers can move according to the shape of the tumor or the design that the radiation is intended to be delivered in. And that allows us to shape the radiation beam and allows us to spare the nearby organs better. So it's very technologically advanced in that way. Here we go. So oftentimes that beam and the machine will rotate around the patient and the tumor and dilute the unwanted dose. And so what do I mean by that? This is an example of what we see when we look at a radiation plan. If a patient is lying on that couch, the front of the patient or the chest is actually here. So if we think about the basic ways of delivering a flashlight or a radiation beam, a very simple way is going directly through, one beam coming from the front and one beam coming from the back. And the way to interpret these radiation heat maps is exactly that. So the hotter colors, the red, the orange, the yellow, are the high dose of radiation or the medium dose of radiation. And then the blue, the cold colors, are the lower doses of radiation. So one of the problems with a very basic way of delivering radiation is that things in front of and behind of the target here in this red circle still receive a relatively high dose of radiation. And so in some ways counterintuitively, when we rotate the beam of radiation around, and we shape with those fingers the radiation beam, we can reduce the amount of the rest of the body of the nearby healthy tissue from receiving those high dose and medium doses of radiation at, in some ways, the cost of the rest of the nearby tissues receiving a very low dose of radiation. Uh, and that actually reduces the side effects from the middle, the moderate, and the high doses of radiation, which are really where a lot of the side effects come from. And so, with each radiation plan, of course, just based on what you've heard from that, you may be able to determine that each plan is unique and designed for each individual patient, because each patient and person's body will be a little bit different. And, the nearby organs and structures and where the radiation needs to go will be a little bit different. So there's a special radiation mapping CT scan. Unfortunately, we can't use any scans that you used before the radiation mapping scan to plan the radiation. And the radiation team designs a unique plan for each individual patient. So how does that happen? So this is an example of what a CT scan might look like. It's basically a lot of different shades of gray. And the radiation team has to decide where the radiation needs to go and where it doesn't need to go. And so that's based on where the disease is, if there is any disease at the time of the radiation, where the disease is likely to be, even though we don't necessarily know that it's there, and then where the disease is unlikely to be, in other words, where the radiation should not go. And so what the radiation team does behind the scenes is, after that CAT scan, we actually draw out where all those individual structures are, as you can see in this cartoon here. And in some ways, we create a work of art based on that. And then what do we do with that drawing? So I don't know if anyone listening is familiar with artificial intelligence and ChatGPT, but they've recently released some very, in my mind, stunning images where computer algorithms have created art from a verbal input. So in this verbal input, they've asked for a close-up of an eye, and in some time frame after that, the computer has generated this what I'll call art of which to me looks very realistic. Um, and so in some ways, on the radiation side, we're doing something similar. We tell the computer what we would like it to do, and then behind the scenes, there's a lot of computer algorithms that take place that are directed by humans. And by the way, there's also very strict quality assurance measures by humans to ensure the plan and the machine are safe to deliver. And then we come out with a plan that looks something like this, where the radiation can be shaped to where it's supposed to go. In this case, it is someone's head and the area behind the eye, this little structure here. And you can see in this heat map that very little of the eye, which is right next to the area that in this case wants to be exposed to radiation, sees very little radiation. And in my mind, that's very elegant and advanced and requires a lot of expertise and in some ways art. So you can kind of surmise then that the what we call the organs at risk depend on the treatment site. So if we're treating your head, then your foot isn't at risk of radiation side effects and vice versa. So some of the common things that we treat then can be very different based on what the neighbor structures are in that way. So if we are treating breast cancer, the things we most commonly think about are the skin, the lungs, and the heart, as these things typically don't need to see radiation from a cancer perspective. If we're treating prostate cancer, the neighbor organs are the bladder, the large bowel, the rectum, the small intestine, and the pelvic bones. And then if we're treating, let's say, throat cancer, there are a lot of structures in that area that we think about and are in some ways sensitive to radiation too. The salivary, the spit glands, the mouth itself, the muscles that help you chew, the muscles that help you swallow, the voice box that helps you hear what I'm saying right now, the esophagus that helps the food get to the stomach, the hearing apparatus, and the spinal cord and the nerves that help you move and feel your arms. So depending on the real estate, as an analogy from real estate, the location is very critical, and what's next to the location is also very critical. And so the side effects of the radiation are really determined by what's next to the target, what's adjacent to it, and that predicts the bystander effects. And in general, and on a very high level, I would say that the side effects are primarily due to inflammation because of the way that the radiation works. It creates inflammation, and so the side effects are due to inflammation. And I also think of them as divided into early side effects and late side effects. That is, side effects early that you might experience during radiotherapy, and late side effects that you might experience after radiotherapy is done. Sometimes that's a few weeks after, sometimes that's months or years after. And those are all in some way due to inflammation. And again, on a very broad or superficial level, you can think of those early inflammatory side effects as being like a sunburn, and those late side effects as being like fibrotic or stiffening of the tissue. So, what is one example of those? If we think about early inflammatory side effects of those common radiation situations, when we're treating a breast cancer, typically the early side effect that we see the most is the skin and a sunburn. For prostate cancer, those early side effects we think about the most are irritability, or if you think of a sunburn of the bladder or the intestine, it's irritability of those tissues. And if it's a throat cancer, we think more about inflammation of the spit glands causing dryness, or maybe some mouth sores, hoarseness, or a sunburn of the skin of the esophagus, so some sore throat. And so what does that sunburn really look like? Is it from the radiation, is it really like a sunburn? This is an example of what radiation sunburn can look like, and there's different degrees from left to right, a low degree versus a high degree of a radiation sunburn. Um,
Dr. Lau, we have a
yeah,
question.
yeah,
Somebody asks, where do the dead cells go?
yeah, great question. So, the dead cells I typically think of them as being absorbed by the body. So your normal immune system will kind of eat away at the dead cells and absorb them and dispose of them in that way. So the body's pretty good at recycling products that it doesn't need anymore, or disposing them through, let's say, the urine or the fecal matter. Any other questions so far? Okay. So the radiation sunburn, there can be different degrees of that. Not everyone certainly will experience the highest degree of radiation sunburn. Not everyone will experience any sunburn at all. Again, it kind of depends on what the neighboring side effects are. If you recall, when we talked about prostate radiation side effects, the skin and a sunburn from the skin wasn't even on that list of common side effects. So it really depends on what we're treating. And something interesting too is what that sunburn looks like depends on the skin tone of a patient. You can see in pigmented skin tones, we typically don't see a red sunburn, it's more of a suntan, and sometimes we see more peeling than anything else.
Another question, somebody asks, what if you're prone to skin cancer?
Yeah, so that's a great question too. Sometimes radiation can bring out precancers. If, let's say, we're treating a breast cancer and we do see a sunburn, sometimes radiation does bring out little pre-skin cancers, and in effect treats those too. We actually do use radiation for skin cancer too. I didn't list that, and we generally don't list that, but skin cancer is the most common cancer in the United States, and radiation is one of the main treatments for skin cancer as well. So we don't always, let's say you have a breast cancer or a prostate cancer, and you also have a long history of skin cancers, or you're prone to developing them. We tend to prioritize in the sense that if we think the breast cancer or the prostate cancer is more, I'll say, significant, then we, in some ways, ignore the propensity to develop skin cancers, and in some ways expect the radiation, if there is a sunburn to the skin in the case of breast cancer, it might actually treat any hidden precancers that may exist. Good question, though. Anything else? Okay. So then, how do we treat radiation sunburns? Well, again, common question, is there anything we or the patient or the doctors can do? We typically do use a variety of topical agents for radiation sunburns. In our clinic, we do tend to like Aquaphor, which is a thick ointment, almost like Vaseline, or 100% aloe vera gel. And in some cases, if you develop that more severe type of radiation sunburn, we might use Silvadene cream. And that can be both prophylactic and therapeutic for the radiation sunburn. There are some, quote unquote, natural ointments too, or creams. There is some evidence, believe it or not, that olive oil can help prevent or reduce radiation sunburns. I haven't had any patients tell me they're using olive oil yet, but I have had patients use coconut oil, and that seems to be reasonable and helpful too. Some patients will also go out and buy other ointments like calendula, Mioderm, Biafine, or other radiation-specific creams that are marketed in that way. I don't personally have a strong preference for those. I'm not opposed to them. They don't interfere with the radiation, and some patients really do swear by them. I would say on the whole, though, on average, I don't see that those are any more helpful than the more cheap or inexpensive ingredients or creams. So I don't necessarily routinely use those. In some high risk situations, though, if your skin at a baseline is very sensitive, let's say the sun, or we expect you to have more of a sunburn for one reason or another, we may ask you to do other prophylactic things preemptively. And so there are some things that are known to help with that in those high risk scenarios, either relatively moderate or high dose steroid creams, barrier films, either in cream or actual film form that you will place on the skin surface. And there's some actually very new and breaking data that suggests that certain bacteria live on every person's skin in some high risk situations can increase the risk of the radiation sunburn and skin infections. So there is some data that decolonizing those bacteria with antibiotics and antibacterial skin cleaning regimens can help reduce the risk of getting those severe sunburns. I would say one of the best things that anyone who thinks might get a radiation sunburn can do is just be gentle with the skin. Don't shave if you're shaving that area. Pat dry after showers. Don't scrub in the shower or bath. Just let the warm soapy water run down the skin and just in some ways baby the area that's at risk, even if it's early in the treatment course. And those are probably the best things we can do to limit the radiation sunburn. Another very common radiation side effect and of interest is not limited to the area that's being treated is fatigue. So that's probably the most common radiation side effect. And whether we're treating, let's say, a breast cancer or a prostate cancer or a foot cancer, those patients commonly experience a degree of fatigue, and that can be multifactorial in origin, meaning it can be the radiation and the inflammation itself, almost like your body's trying to fight off a cold. You might feel your feet dragging a little bit. It can also be from the transportation and coming back and forth from the radiation center. Again, radiation is typically every day for several weeks. Or it can be from other things leading up to the radiation. Some patients have had surgery or chemotherapy before, and it can be a bit of a cumulative effect. So there can be different things that cause that, but fatigue is very common during radiation. So is there anything you can do about that? I think it's very general information, but the best thing I can say is a normal, healthy diet. During radiation therapy or cancer treatment in general, we typically don't want patients to actively try to lose weight and try to maintain their weight. And the best way to do that is, considering protein-rich foods or high-calorie foods, and not necessarily trying to eat healthy in the sense of dieting, eating, only fruits and vegetables, that sort of thing. It's not the right time to diet, but a normal healthy diet with a the standard food pyramid is probably the best thing from a diet perspective you can do. Also try to maintain a safe level of activity. So don't try to run a marathon, the day you start the radiation, but keep the legs moving, try to walk a block around the house or something like that. Just try not to, if possible, and safe to do so. Just try not to, stay in a chair or bed all day. And also, in that same vein, try to avoid taking naps if possible. Small naps are okay, but if that nap ends up being a few hours and there's multiple naps every day, that can also make it harder to fight off the fatigue. So we try to, in some ways, push through the fatigue if someone's able to do that in a safe way. So a common question that we get related to the diet issue is about vitamins, supplements. Can vitamins reduce the radiation side effects? Well, some vitamins are antioxidants, and as we discussed before, one of the main ways radiation works is through oxidation. So there is a risk of counteracting the therapeutic, the beneficial effect of radiation treatment in hurting those cancer cells, unfortunately, as well. So I think in general, we want the goal to be that all of the nutrition, the calories, the vitamins, the minerals coming through food and drink orally, if possible. Some things are okay, like vitamin D, for example, is okay. That's not an antioxidant, and if there's a known deficiency, so some patients are known to be deficient in certain vitamins other than vitamin D, that can be okay. But the thing that we try to avoid is high doses in certain vitamins, like high dose vitamin C specific supplement would be less okay. Although a daily multivitamin that has, 100% of the daily recommended value should be okay, with the caveat that we would like the nutrition instead to be through, oral food and drink rather than a pill if possible. One thing I will say, and this information is not specifically from me, but rather through the University of Pennsylvania, is that supplements are known to be not rigorously regulated by the FDA, and that includes even multivitamins or a vitamin C supplement. And in one study, 60% of supplements did not even contain the label ingredient, and other things can be added to those supplements that we may not really be sure what they are. So there can be, hormone additives in there and other things. So it just creates some question marks of, specifically during radiation therapy, how that might interact with the oxidative effect of the radiation. Another common question we get is about sugar. Should we avoid sugar? Is that what caused the cancer? Does that help the cancer grow? There is what we know the Warburg effect, where cancer cells have a high sugar metabolism. They take up a lot of sugar and they use that sugar. And that's in fact how a PET scan works, a PET scan works. It's based on sugar metabolism. So the theory is, can we starve cancer cells by cutting sugar out of the diet? The problem with that, though, is that it requires a pretty strict, what's known as a keto or ketogenic diet. And there's an example of that here on the right, where you need to avoid fruit and carbohydrates, essentially, including, sweets. Some fruits and vegetables actually have a reasonable amount of carbohydrates in them too, so you have to limit those. And the ketogenic diet then is really in some ways similar to an Atkins diet, where it's high in protein and high in fats. And so, if you can do that, and if that's of interest to you, I don't think that's unreasonable, but it really is important to still try to get in the calories with the fat and the protein. And something else to note is that the body is really good at processing even healthy foods, those fruits and vegetables, into sugar. And in a starvation setting, where you really are cutting out sugar and other food, the body really sacrifices fat and muscle even to create that sugar. So, again, it goes back to the idea that going on a diet and trying to starve the cancer can be really challenging even on the normal healthy cells, and may not really be desirable during cancer therapy in general and radiation therapy.
So we have a question or a comment. She said a big issue is balancing bowel movements between constipation and diarrhea. What about taking supplements to balance that?
Yeah, so I think you're right, especially with pelvic radiation, like prostate or gynecologic areas, bowel movements, and a bit of a seesaw between constipation and loose stools can be challenging. And so we do sometimes use supplements like magnesium citrate or stool softeners like Colace and Miralax to help with that, or on the flip side of that, Imodium, as the commenter may note. And those things are okay because we don't want you to suffer from those issues. Sometimes during pelvic radiation, also certain food items can trigger loose stools. And so your radiation team may have some input there. Typically, those we suggest what I would call a low residue diet, so avoiding things that leave behind things in the gastrointestinal tract, like corn, peas, leafy greens. Other things like dairy can sometimes trigger diarrhea as well, and whole grains is also leave some residue behind. So there are certain dietary things that we may try to avoid, and certain supplements that we try to use as needed for that those issues. We do want, and every case is different again, but we do typically try to avoid a seesaw effect and try to stay even keel, whether that may be a little bit more on the constipated side or a little bit more on the looser stool side. So there is a bit of a balancing act there, but that low residue diet, in some ways, interestingly enough, is like a ketogenic diet, which is high in lean proteins as well. I hope that helps that question. Anything else so far? But that's actually good because it's about time for your questions now. So the conclusion so far is that again, radiation therapy or radiation treatment is commonly used for many cancers. There are different forms of radiation. The most common form is external radiation, so that's what we focused on today. Modern radiation therapy is highly precise and highly technologically advanced in most cases. I can only speak for our group at Coastal Radiation Oncology. There probably are some centers in the United States even that do not use the highly advanced techniques, but at Coastal Radiation Oncology we do. I also consider it a form of art because there is a lot of what I'll call drawing and thinking about what needs to see radiation and what doesn't. The side effects are generally inflammatory in nature and linked to the neighbors of the target area. And the management really does depend on the body location and the severity of the side effects of the radiation. But really, the first principles are the best practices, and that is a normal, healthy diet, a safe level of activity, in some cases, prioritizing, delegating, and enlisting help if needed, and trying to get restful sleep at night if possible. And again, feel free to call, email, speak up if there's any questions or concerns. I do have one hidden slide for what I think may be a question, but I'll see if there's any things that are interested of being asked.